Assalamu alaikum again. Today's lecture, we're going to have only one topic related to the general introduction to the new topic of computer-aided diagnosis, which will be the topic for research problem 2. Before we get started on that, do you have any questions about the second assignment for research problem 1? Any questions about assignment 2 before we we're going to get started on the lecture. Very general introduction of artificial intelligence in healthcare, which of computer-aided diagnosis. So computer-aided diagnostic systems are basically a part of artificial intelligence in healthcare in general. Okay? I'm going to take medical imaging in general, okay, in 6-7. Okay. During this presentation, please stop me at any time because this is a very general presentation, and I'm planning to give. Okay, so each one of the theoretical lectures an assignment on Blackboard that consists of multiple choice questions and true-false questions, so that I can make sure that you understand everything. So basically, artificial intelligence in general, if you want to define it, it covers a broad range of technologies involved. So humans traditionally did, due to several reasons, in these tasks. Okay, we're going to say why in a second. Okay, there are so many applications of artificial intelligence that include what's the meaning of prognosis? Right? What is the meaning of prognosis?
Like a prediction.
Like what?
Like a prediction.
Yes, prediction of the development of the case. Okay, so basically diagnosis would tell you the current situation. Here, basically, so the future development is basically prognosis. Okay, therapy, of course, we know what the meaning of therapy, and big data analysis. Big data analysis is now a very hot topic. This is basically one of the very hot topics at this time because you know, we have so many hospitals, we have so many patients, and we have their data stored in these hospitals databases. And basically, if you look at the data from so many patients, you can actually find things that you cannot find from the data of very few patients. So basically, instead of just looking at the patient at hand, you're looking at so many different cases that had similar diagnosis. From these patients into account when you're making decisions for the current patient. And this is a very large of the hot topics that people are talking about. Really nice topics that you can consider. So, for example, solutions are utilized to develop computer-aided diagnosis. So basically, our topic, which is computer-aided diagnosis, basically is just a subtopic of artificial intelligence in medicine that deals with diagnosis, basically. Okay. In order for us to understand things, or basically be a little bit specific, so that you can understand, and for me to be able to give you specific examples, we will consider a focused approach. Basically, we're just going to consider medical imaging, for mammography. Basically, when you're trying to consider a certain computer-aided diagnostic system, you have to was used. Okay, so basically we're taking images from radiology, from radiological scans, and the application is breast cancer in particular. Techniques, as we're going to see, actually there are so many different techniques. Basically, you can on, for example, lab data, for example, or from the history, or from genetic information, for example. Okay, so here we're considering radiology, just images from radiology, just scans. Okay, the application is breast, the same computer-aided diagnostic system with the like breast cancer, like skin cancer, like lung cancer. Just a matter of picking an example. Okay, what we're going to talk about can apply to several other things. Talking about things that are specific to mammography without loss of generality. Okay, so basically, this is without loss of generality. Generalized to other applications, other techniques in cancer, like lung cancer, things of that sort. Okay. So, as in order for us to for a particular application, data about why this application is very important, artificial intelligence in that particular area. So breast cancer is the most common cancer in women, and it is the main cause of death from cancer among women in the world right now. Based on World Health, based on the best available current evidence, screening exam should be recommended every 1 to 2 years for women between 40 and 74 years of age. Okay, I'm talking about average risk history, family history of breast cancer. Okay, average risk, the woman has her mother, for example, or her sister, other women. Not an average risk. She will need to have more scans. But I'm talking about the average women should have a breast scan, like screening exam. Screening, we're going to talk about this word. This is a very important word. You know what the meaning of screening? Okay, screening basically X-ray scan or something like that to catch the early malignancy. Okay, so basically screening means that we're just like testing all women just to catch the early beginnings of cancer. Okay, if the woman has a complaint like a mass or something like that, then this is not screening. This is clinical. Okay, that we're going to talk about this right now. So basically, a screening exam is shown to reduce breast cancer mortality by 38 to 48%. I'm talking about when the woman is diagnosed with cancer. I'm talking about between 38 and 48% can be basically saved if you actually catch the cancer early. Okay, so this is very important. Suspicious cases are called back for further diagnostic evaluation. Of course, as you will know now, as we basically will learn together in a few minutes, basically sometimes it's very difficult to catch early start of cancer. But actually sometimes when you have some suspicious cases that experience certain symptoms, or basically their scans show certain things that are not cancer, but they might be precursor to cancer. Okay, so basically these are called for further diagnostic evaluation. It's not like she's going to have to wait for 1 year. It might be recalled in 6 months or something like that to basically follow up on her case. Okay, so basically screening is very important. Okay, and basically through screening you can catch cancer early, and basically you can treat it early, and so you can actually save more women and reduce the breast cancer mortality. Of course, radiology is the best diagnostic exam for breast cancer. Basically, imagine that the alternative radiology is basically lab analysis, just taking a biopsy. Biopsy is invasive. You just go in and take a biopsy, take a sample, okay? And if you're talking about screening, this is not possible at all, basically. Because basically you don't know where the cancer starts, okay? So basically you cannot use it for screening. You can actually use radiology or biopsy for cases with masses, for example, but not for screening. So basically radiology is very important because it's the best diagnostic exam, because basically it's non-invasive, and basically it can be used for screening. We differentiate between these two different scans. The one that we talked about, which is screening radiology, we're talking about asymptomatic subjects. Basically, symptom is basically the things that the patient feels. Okay, the patient has mass, for example, okay, or has certain problem in certain areas of the breast, for example. Okay, asymptomatic means no symptoms. Okay, it doesn't complain of anything. Just a regular woman doesn't have a complaint about breast cancer at all. So you're screening because you actually want to catch things before they develop to become something that is symptomatic. For clinical radiology, it's different. It is basically the woman feels something, and basically she goes to the doctor to see what that is. So for example, a woman has or feels a mass, and she goes to the doctor to diagnose whether it's benign or malignant. Okay, so basically, if a woman goes with symptoms, then we're talking about clinical radiology, not screening radiology. Okay, clinical radiology, basically the woman has a complaint, has a problem, and she goes to the doctor to diagnose this problem and start treatment if needed. Okay? So basically, we have to differentiate between these two, because actually the system for diagnosis in both of these types of radiology are very different. Have any questions? So radiology actually is not just one technique, as you know. Okay, we have so many different techniques. Okay, the X-ray mammography is basically the gold standard at this time. Basically, it's sometimes it's film-based. It was actually film-based until maybe mid 1990s or something like that, and then it actually transformed to digital imaging. The film-based actually was very popular because the resolution is really high. You cannot compare the resolution of a film to whatever digital system that you have. Okay, the resolution of digital system is definitely much lower than any film. Okay, but the problem is with films, sometimes the development of the film or the exposure parameters of the film might actually change the contrast of the film. So basically in digital imaging, as we saw in the first part of this course, we can actually modify the contrast. We can basically reduce the noise. We can display the image with different windows, things of that sort, and we can actually improve the quality. And basically, this actually compensates for the lack of resolution of digital imaging. Okay, so digital imaging actually also allows low dose X-rays to be used. But usually the doses of X-ray that are used in both film-based and digital imaging are much lower than the regular applications of X-rays. So basically, you cannot compare it, for example, to angiography or something like that. You need much higher doses for angiography. If you're talking about bone imaging, if you have bone fracture, something like that, they're much higher than the ones used in mammography. Okay, so now basically almost exclusively all the systems are digital. Okay, exclusive. Okay. X-rays, by the way, X-rays are usually projection imaging. So basically in X-rays, as you know, you just take a projection of the structure or the subject that you're imaging. So basically this is projection imaging. You're taking a projection image in certain direction and that's it. And the projection basically superimposes different structures, if you have a 3D structure, like the breast, for example, everything will be superimposed in the direction of projection. Okay, so for example, if I'm imaging a subject, if the subject is here, okay, and your imaging X-ray is right there, okay, if you have a line of X-ray going through the subject, all the points here will be superimposed on one point right there. And this is a disadvantage, of course, because sometimes the contrast is lost when you do that. If you have a small change here, for example, you have a certain area that has a very small change, okay? It's very difficult when you add so many other points. It's very difficult to basically detect the change here unless it's very large. So this is a disadvantage, okay? This is a disadvantage for X-ray mammography. It is still the gold standard, but actually it's not the best in terms of what you can do. Okay, some people thought about basically, of course, some people can think about using CT, for example. Okay, if you want to get the volume image or basically scan the breast as a 3D structure and getting the information in, from every pixel as a certain point. Okay, if you're using 3D, CT can be used. But the problem with CT is the dose. You have to have low dose. Actually, CT is not very good with the dose. If you're talking about a patient who is going to experience this type of scan every year, this is not a good thing. Okay, so CT is very seldomly used for mammography. The alternative is something called tomosynthesis. Tomosynthesis uses a system that looks like this, and actually it's a very specialized low-dose computed tomography. So basically, if you need to have a 3-dimensional scan of the breast, you can use X-ray tomosynthesis. Okay, we're going to talk about this. This is a very good technique, but it's a bit expensive and it's tiresome, for the doctors. So instead of the doctor, basically, usually when you're trying to scan the breast, you usually scan from 2 directions. Okay, so basically you scan what's called CCMLO, Craniocodin and Mediolator Oblique, 2 directions. Basically, you end up with 2 images for the regular X-ray mammography. If you're talking about tomosynthesis, you end up with maybe 50 to 100 images. Okay. And this is a big problem because basically if you're imagining a doctor who has to go through 2 images to diagnose a case, the same doctor has to go through 100 images to diagnose the same case if it was scanned with tomosynthesis. So basically this is one of the problems that will actually motivate people to do computer-aided diagnosis, because it's extremely difficult for people to use something like tomosynthesis, or basically the number of images that come out of this scan is so huge and it's very difficult to find doctors or basically do the interpretation or the diagnosis from the images in a timely manner. So this is used, but actually it is usually used for clinical, not for screening because of the problems in the number of images out. There are other techniques that actually became very popular, which are like ultrasound imaging and MRI. They are both used right now, but they are not with the same quality as X-ray mammography. The resolution here is much lower, and here also it's a bit lower than X-ray mammography, and this is very expensive. Okay, this is not expensive, but the resolution is much lower. It's extremely difficult to see the early beginnings of cancer from ultrasound imaging. Okay, so basically, ultrasound imaging, the resolution is very low. Here also, the resolution is not very high, it's definitely lower than X-ray mammography, and the cost is extremely high. There are several techniques in mammography, like elastography, things of that sort, that are promising, but they are not yet there. Okay, because of the cost, because of the lower resolution, basically, it's not that widely used in mammography. Okay, so these two are okay, but they are not usually used unless X-ray mammography is not available. There are several emerging techniques that people actually are currently developing, but they are not there yet. They are not really, at least they are not present as commercial systems to be used for screening of mammography, like molecular imaging, like optoacoustic imaging, like ultrasound tomography. Basically here, instead of using X-ray to do three-dimensional scan, we're using ultrasound to do tomography, near-infrared imaging. These kinds of techniques actually they have promise, but they are not still available. They are not available commercially yet. But probably things like ultrasound tomography, for example, it might be really promising because actually we get rid completely of the ionizing radiation X-rays, and basically you can get three-dimensional imaging. This can actually, the three-dimensional information can compensate for the lack of resolution, so it might be a little bit, promising. Okay, and also because it's ultrasound, usually ultrasound imaging techniques are much lower in cost than CT or even tomosynthesis. So basically, it might be a little bit promising. The techniques that are like near-infrared imaging, optical imaging, one of the types of optical imaging. Molecular imaging also is very promising, but actually this is a kind of, it's mostly MRI. Okay, there are several techniques that can be used for molecular imaging, but molecular MRI in particular is probably the most promising of these. So basically there are several other techniques that can be considered in the future. But right now, what we're talking about is X-ray mammography because it's the most widely used. If a woman goes today to do a screening mammography, it will definitely do that with X-rays. It's not going to do it with any of the other techniques. You have any questions? I'm just trying to explain the technique that is used and why. Okay, we move on to the actual problem, which is a mammography reading. Okay, as I was saying, X-ray images are captured from two angles of each breast. Basically, what I told you, CC, it's craniocodal, and mediolateral oblique. Basically, these are the two techniques that are used. Basically, craniocodal is cranio is basically it's the brain. Okay, caudal is basically the end of the vertebral column. Okay, so basically it's from up to down, up down. Okay, and basically this is an example of craniocodal imaging. Okay, this is a mediolateral oblique scan, for example. Okay, so basically you have two scans like this, and basically a doctor sits in front of the film. If it's film based, or in front of the monitor if it's a digital system based, okay, and tries to basically magnify the different areas so that he can detect the early beginnings of cancer. The early beginnings of cancer are called microcalcifications. Okay, microcalcifications are deposits of calcium. Okay, very small deposit of calcium. Okay, they are generated from the cancer cells. Okay, when they are growing. Okay, so these appear as very bright dots in the middle of the normal texture of the breast. Okay, so basically they are very small. They are extremely difficult to detect. But actually, you have to detect them in order for the woman to get. Okay? So basically, if we're talking about film-based, the doctor would sit in front of the lamp, X-ray lamp. He posts the images and basically has a magnifying glass and basically goes over the image in different places and tries to detect where microcalcifications might be. Here, you can actually do the same. Basically, you can just magnify a certain, of course, if you have an image, you can magnify the image. You already did that in the first part of this course. You can magnify the image and just scan it so that you can detect any variation. So the doctor can scan and detect the microcalcifications if they are present. You can actually also manipulate the image. You can enhance the contrast. He can basically remove noise. He can do all kinds of processing so that he can actually better view the image so that he can come up with a better diagnosis for the case. Okay, so basically, as you can imagine, just to give you an idea, basically the resolution for film-based is also infinity. The resolution here, the resolution of each image that is basically generated from digital mammography, we're talking about 5K by 5K. This is the average. It can be higher, it can be lower, a little bit lower, okay? Imagine that you're looking at an image that is 5,000 by 5,000. The HD monitors that you have at home, for example, the resolution is 1920 by 1080. So if you're trying to display something like this, you cannot display it on a monitor like this. You can basically view a part of the image, and basically you have to, in this direction, you have to at least do that about 3 times. You can move up and down 3 times. Here you have to move at least 5 times. So basically, it's if your image is like this, your monitor is seeing a part that looks like this. And you have to basically move the image, move each direction here and here and here and here, so that you can actually look at the image. It's extremely difficult. Okay, so the images, if you're talking about just 2 images, okay, basically of each breast. So basically, if the woman is scanning, basically you usually have 4 images, okay, for the 2 breasts, and it's inspected for malignant lesions by 1 or 2 experienced radiologists. Okay, so basically you have 4 images. And you have you do that twice, okay? And basically the reading process is extremely tiring, it's extremely lengthy, it's costly, and definitely because you have a human subject, human radiologist, it's prone to error. Imagine that the doctor is basically reading 100 images every day, for example, okay? Basically you will be so much more tired at the end of the day than at the beginning. So basically it's prone to errors. It's susceptible to errors. Okay, and it's costly because the cost of radiologists is extremely high. Basically, it's basically, at least in the US, we're talking about salaries that are much higher than any other place, and basically even here in Saudi Arabia, doctor hours is much higher than anybody else. So it's very costly. And basically, the shortage of radiologists is compounded by the increase in the volume of data. The increase in the volume of data is coming from two things, basically. Coming from more cases, and coming from more images. More images, like for example, if people are using, we're talking about tomosynthesis, for example, we're talking about 50 times, 50 times the number of images in the regular X-ray mammography. So basically, with these two, you can have a problem because basically the number of radiologists didn't increase. So basically, when the number of cases increase because of the expansion of screening programs, and the number of images might also increase if tomosynthesis is included, then you have a problem. Okay? For this part here, one of the very important things that you have to talk about is basically liability. Meaning that the doctor, if the doctor misses a lesion, misses a part of the image that has cancer, and the woman develops cancer, and basically it might basically its survival might be jeopardized because of that, they can actually sue the doctor. They can actually have a lawsuit, and they can basically have a problem, cause a problem to the doctor. So basically, it's a big problem. Actually, it's a big problem from every angle. Every angle you look at, it's a big problem. And talking about two radiologists, okay? Basically, all the images must be read by two, and basically these two might have different opinions. Which one would you take? Probably when you have one is yes, one is no, for example, you have to actually arbitrate and have another third radiologist, which actually one of the things that we basically compound the problem of shortage of radiologists. Okay, so can you imagine the problem? Imagine the problem why computer-aided diagnosis was actually one of the things that people thought about. It's because of things like that. Okay, have a problem in reading that much volume, and you have a problem because you don't have basically enough radiologists for the volumes of images that are generated every day. You have a problem in the liability, you have a problem in the accuracy of the diagnosis, things of that sort. You have a problem also in the lengthy process that actually make the diagnosis a little bit slower. All these problems actually motivate us to move to computer-aided diagnosis.
Doctor,
yes, go ahead.
what time normally the doctor diagnose analyze the image, and like one day or some certain day?
Actually, it depends on the doctor. It basically depends on the doctor. Basically, some doctors actually are fast, some doctors are slow, but the average is very, very slow because basically you have to look at really large images, and it takes hours to do that. Okay, so it's a real problem, especially for the screening programs. We're talking about the clinical mammography. That's different because actually he knows where the mass is. So he basically goes directly to the place where the mass is and tries to diagnose this particular part. For the screening mammography, he doesn't know where the microcalcification might pop up. Okay, the microcalcifications can be anywhere in the breast, and he doesn't know where it is. Okay. It's like one of these puzzles actually where you have an image and they ask you to find a certain pattern in that image, and it's extremely difficult because the images are extremely large. Okay.
Do the doctor also use image manipulation? Some
Yes, yes, of course. It depends. Basically, if every doctor, as a start, every doctor likes a certain setting for the monitor. Okay. And every doctor likes to see the lesion in a particular way, okay? So everyone has a pattern, a certain pattern of processing the images before they make the diagnosis. So basically, some parts of the image also might be okay to see without pre-processing. Some images would require pre-processing so that you can see them a little bit clearer, okay? So basically, it depends. Okay.
Okay, doctor.
Okay. So in order for us to talk about computer-aided diagnosis, let us first talk about measures of diagnostic performance. Okay. First of all, of of course, if we have a case, this is basically the reference standard. This is the truth, okay? And this is the diagnosis, okay? You have this matrix right there. Positive means the disease is in. Basically, there is a disease there. The case is, for example, malignant, okay? Positive means it's not good, actually. It's the opposite of what you think. Basically, positive means that it's confirmed to have a disease, okay? It's abnormal, okay? Negative means it's okay, okay? Negative, so basically, it's nothing is there, okay? So the case might be positive or negative. And the radiological examination can be either positive or negative. So basically, the doctor who does the diagnostic examination or the radiologic examination doesn't know the reference standard, doesn't know the truth. He's trying to detect the basically the presence of the disease from the image itself. So he can come up with positive or negative. And if it is exactly the same as the truth, then we call it the true positive. True positive means that you diagnose the positive case correctly as positive. You can also have true negative, meaning that basically the case was negative and the diagnosis was negative. We have two other cases where the diagnosis is different from the truth, okay? If the radiologist said it's positive and it is actually negative, we call it false positive. Because actually it's not positive, it's false positive, okay? So he basically said there is a problem and there was actually none. Here it's the opposite. The doctor said that it's negative while it's actually positive, okay? So as you can see, these two cases are actually different. Which one is more important? Which one is more dangerous? Let me just put it like this. Which one is more dangerous to the patient? Which one would cause more problems to the patient?
False negative, I think.
Yes, exactly, false negative. Okay, this is very dangerous. Okay, so basically this is a problem because the woman goes to the doctor, takes a scan, she has a problem, and the doctor didn't see the problem. So he would tell her that you are okay, please come back in 2 years. Okay, what do you think would happen in these 2 years? The early symptoms that were supposed to be detected in the initial scan would continue to grow, and basically she would come with a bigger problem in 6 months. And probably the survivability or the mortality of our case will be much worse than, if she were basically diagnosed correctly in the first scan. The false positive is not good, of course. Okay, anything other than the true positive or true negative is definitely not good. But actually, this is a little bit less. This is, maybe we can call it inconvenient. This is basically dangerous. Okay, inconvenient means that the woman goes to the doctor, if she doesn't have any problem. The doctor tells her that you might have cancer. She's basically a part of from the emotional and psychological damage or psychological problem that she will suffer, her and her family. Basically, she might have to go through additional scans. Basically, if the doctor in a screening exam says that you have a problem, then you have to have a biopsy, for example. This is an invasive procedure. Okay, so the patient would have to go through extra procedures, will have to suffer emotional agony, and at the end, she will find out that she doesn't have any problem. Because of basically, the initial scan was incorrect. The diagnosis in the initial scan was incorrect. This is not nice, but it's much less dangerous than having a problem and not diagnosed. Okay. Usually, when you have this is for what they call this particular matrix called the confusion matrix. Okay, this confusion matrix is very important to show the different aspects of the performance of a particular test or a particular radiological examination. But the numbers themselves might not be very clear to understand. Okay, so people thought about certain measures that basically once you compute this matrix, you can use TP, FP, FN, TN, and compute sensitivity, specificity, predictive, positive predictive value, negative predictive value, and overall accuracy. Of course, we know the overall accuracy is, by definition, the true over the total. This is true over the total. Okay, it's not a big deal. It's very clear. We know about this. Basically, this is what comes in mind when you think about making decisions and comparing them to the correct decisions. Okay, this is like grading an exam, basically. Basically, the other measures are really very useful because they look at different aspects of the performance of the diagnostic exam. Okay, for example, the sensitivity, or what they call it, true positive rate, is the ability to identify the presence of the disease. Okay, it's TP over TP plus FN. It's looking at, basically, we're talking about this. Talking about this column. Okay, these are the positives. How many of the positives you were able to diagnose as positive? This is the sensitivity. So if you have a sensitivity of 100%, this means that you basically detected all the positive cases in the reference standard, or all the positive cases that came into the exam correctly. The specificity looks at the negative column here. Specificity is the ability to identify the absence of disease. It's basically the true negative over the total here. So if I have a specificity of 50%, for example, it means that 50%, if you have people coming in without a disease, and you have a specificity of 50%, it means that 50% of cases that come in will be diagnosed as positive, while they are negative. So basically, what you will need to have is a very high sensitivity and a very high specificity together. Okay? Why together? Let me give you an example. For example, imagine that I have a black box like this. This is, let me put it in another, I will diagnose, I will put a CAD system, my CAD system, this is my CAD system. I will design a CAD system that will take a mammography case and give a decision. Okay, this is my CAD case. And basically, I design this CAD block to give one all the time, regardless of whatever the case is. What would happen if I do that? Basically, if I give one all the time, it means that all the true positives will be detected. Because basically, if I have a positive case here, it's guaranteed to give one here, to give positive. Here. One means positive. Okay, let me just put it as positive so that you don't get confused. Basically, it gives positive all the time. Okay, so if you have a positive case, it will give you positive all the time. So basically, all positive cases will be detected, will be correct. So basically, this will be 100%. The sensitivity will be 100% for this. Okay. How about if you have a negative case? If you have a negative case, the outcome here will be positive, which means what? Basically, all the cases will be basically because actually the radiologic examination will give only positive. It will never give negative. So basically, all the cases will be here, false positives. So the sensitivity for this the sensitivity here will be 100%, while the specificity will be 0%. So it doesn't make any sense to look only at the sensitivity. It doesn't make any sense to do that. Because basically, if you have a sensitivity of 100%, you can design a system that has a sensitivity of 100% without actually doing anything. Just a matter of you don't really look at the case at all, you just give positive all the time. You have to look at both at the same time. You have to actually target that these two are almost exactly the same value, or this can be a little bit higher, but they have to be almost in the same vicinity. For example, if you have a system that has a sensitivity of 90% and a specificity of 85%, this is okay. Okay, it doesn't make sense to have a sensitivity of 95% and the specificity of 50%. This is not acceptable. These are not close. Okay, you have to always target that the sensitivity and specificity are close together, are not very far like this. Okay, so this is one of the things that people actually use. We're going to go into details about this in the next lectures, but I just want you to get the concept here. Okay, so this is very important. Sensitivity and specificity, you actually look at them together. And basically, these are the measure that biostatisticians use in order to evaluate the performance. Okay, and it's very important to understand both of them. There's something called positive predictive value and negative predictive value. Okay, this is the reliability of the positive result. Basically, if I get a positive result from here, okay, positive result, like basically if I say that it's positive, how reliable is that positive result? Meaning that basically in this case I'm looking at the instead of looking at the columns, I'm here looking at the row. Or basically the positive predictive value will look at the first row, the negative predictive value will look at the second row. Here you're looking at how many positive were true compared to the number of cases that were diagnosed as positive. Okay, if a doctor has 100 cases, okay, and basically if he has the true positives were like 10, the false positives were like 10, okay, it means that for the positive cases that he diagnosed, it's only 50% that basically the true ones were 50% of the total, meaning that if you go to this doctor and tells you that you are positive, then basically it's 50-50. You have to actually consider taking another exam or going to another doctor, because actually the diagnosis is not reliable. 50% is not reliable. It's just a flip of a coin. Just flip a coin. It's not really a matter of it's not really a confirmed positive in this case. Okay, so you have to look at this way basically. This is the pre-test, meaning that before you go to the test, before you take the test, you go to the test that gives you the high sensitivity and specificity. The post-test, like the positive predictive value and the negative predictive value, will give you the reliability of the result. If you get the result, you get the result as positive. How reliable is that positive result? Okay, this is what the positive predictive value and the negative predictive value give you. Okay, so basically they are the true positive or the total, and here it's the true negative over the total. Okay, so actually if you want to give a complete picture of a particular examination, of a particular performance of a system for diagnosis, you have to actually consider all these performance measures. Okay, and if you don't do that, if you just use the accuracy, then you have a problem, because basically this is what most people would do actually. If you are talking about an engineer, you're talking about true and false, basically. Just considering the summation of the true over the total. But the problem is, if you put it like this, then the false positive and the false negative are exactly the same then. If you have many false negatives and 0 false positives, it will be exactly the same as you have all false positives and 0 false negatives. So basically, the accuracy is not a very good measure because it doesn't differentiate between the false positives and the false negatives. Okay, this is one of the things that we're going to basically implement in our research problem too, because it's very important to compute such measures from basically just to evaluate a particular diagnostic system that we build. Have any questions? For clinical diagnosis, if we want to talk about the reality of things, okay, for the clinical radiology, basically, if you're talking about clinical radiology, you want to have examinations with high sensitivity, even in the presence of a relatively low specificity. In the screening radiology, you have to have very high specificity and accepting a trade-off consistency. What's the meaning of that? Here, a woman comes with a mass, okay? You want to make sure that this mass is not malignant, okay? So your highest priority here is to detect whether this mass is malignant or not. So you have to have very high sensitivity, okay? You cannot compromise sensitivity in this case.